conversation, but I do really want to introduce Dr. Mariam Savabi, because we're in for a treat. Her? They, them. They are a practicing obstetrician and gynecologist and a faculty member at the Puyallup Tribal Health Authority, dedicated to advancing anti-oppression and social justice in healthcare. They created the Healthcare Anti-Oppression Institute to train medical professionals on anti-oppression practices. With over a decade of experience as a clinical OBGYN, Dr. Savabi completed their residency at the University of New Mexico, where they developed an anti-oppression advocacy curriculum adopted by multiple programs and received the Ryan Program Resident Award for Excellence in Family Planning. Holding a Master in Public Health from Columbia University with a focus on maternal mortality, they consulted for the UN and authored a report on Tanzania's maternal health. Dr. Savabi currently serves as the DEI Chair for ACOG District 8 and has participated in ACOG's National Diversity, Equity, and Inclusion Excellence Work Group. They earned their MD at the University of Kansas, where they created a credit-based anti-oppression training for medical students and received the Student Diversity Award. Their prior experience as a sexuality and diversity education specialist for Planned Parenthood underscores their commitment to equitable healthcare. Growing up in a low-income environment as a queer person of color and a daughter of an immigrant and refugee, their lived experience drives their advocacy for justice in women's healthcare. Please join me in welcoming Dr. Savabi.
Okay, I also did not know that was going to be read. Hello everybody, Mariam Savabi, it's so nice to meet you all. So this is just some information about me, but let's get going. Let's start with a little bit of an exercise, so if you're able to participate and how you're willing. So if you want to reach up to the sky for inspiration, get a good stretch in. Reach down to get power from the grassroots. Stomp out injustice as much as we can. And then the last one, I love to take photos of everybody doing it. We're going to move in the winds of change. Oh, I love it. Okay. Okay, thank you. I have no disclosures, wish I did. Okay, objectives. Wish someone was paying me. So we're going to define oppression, because I think oppression is like this really terrifying word and we all hate it inherently, but like what does it mean and how is it created in society? We're going to identify targeted identities and how that ties into the social determinants of health. We're going to talk about adverse patient outcomes as it relates to oppression and challenge our own participation in oppression. And so the idea is that we learn to interrupt oppression when we see it so that we're not participating in it. I'm going to have to fly through this, so I will talk a touch fast, but we will have questions, and I'm always happy to be a resource anytime in the future. I'll share my personal contact info at the end. My bio kind of talked a little bit about this, but I think my personal identities brought me into this work. I didn't realize why I was treated differently growing up, and I thought it was something wrong with me. But then as I grew and I learned about oppression, I realized it was actually something wrong with society, you know? And so that journey has been what has brought me into this work, and this language has given me the ability to liberate myself. And so I think it's really important that we talk about it openly, especially in the aspects of healthcare. I pursued obstetrics and gynecology. I was previously public health and worked in the city center of St. Louis in really, really difficult environments as a sex educator. It was like the best job in the world, but I knew that I really wasn't going to be able to make the impact I wanted to, so I decided to go into medicine, which was a very long, difficult journey. And I think in the process has taught me about all the different levels. I've seen it, you know, participated in it both as a person and also now being part of the system of oppression. It's exhausting and it's difficult to constantly be challenging it, but this work is what liberates me, and I think it's what allows us to change outcomes, and I think that's why we're all in this room today, because we're questioning systems and we want better both for ourselves, our communities, and our patients. So this is what has driven me to be here today. And please take pictures of slides, but credit me. I'm not the best at crediting myself, so that would be very helpful. And then I do want to start with an occupied land acknowledgement. Sometimes this is, you know, like how helpful is it to really acknowledge that we sit in this meeting on the land of other people that have had to be colonized in order to have this conversation. But I think it's important that we acknowledge it and that we turn that knowledge into action. And I'll give you some constructive ways to create action. I think money is always the easiest way and a very powerful way to do so as well. But unless you're a native, we do live on native land, and so I think it's important to acknowledge that we are currently on the land of the Puyallup tribal people. We need to honor the land and the people, both past and present, the injustices that have been experienced on this very land for us to have this beautiful water view today. And please learn about the land you occupy. There's this website and this tech you can actually text, and you can share your zip code and it can tell you whose land you occupy. Again, this is also just for tribal communities that are registered within the US government. But this is a map. Wow. Yes, these images aren't going to be great, but this is like a good map of the Salish coastal peoples, tribal lands that are registered within the U.S. government. Again, there's other tribal people that aren't registered within the U.S. government, but we sit on the land of the Puyallup tribal people. And there are ways to get involved just within our local community. They have a wonderful website, they have a Facebook where they're constantly posting events, and they just recently opened, the Puyallup tribal people opened up their own restaurant, Woven on Reston. So go spend some money. But it's important for us to be involved in our community. So community standards, we're going to be talking, like I'll be talking now, but then you're going to have an opportunity to speak amongst yourselves. So it's important to create some community standards. Usually I ask you to volunteer them, but since we don't have the time, I'll just set these and you all can talk about others that you would like to establish for your conversation, but share what you feel comfortable. Try to use I statements. I'm not here to have you be triggered or to expose difficult parts of your past if you don't feel safe. And so please just truly share what you feel comfortable, because there's not the opportunity to debrief. Debrief is one of the most important parts of the work within anti-oppression work, and I'll talk about that a little bit later. But if you want to do this work, I encourage you to do it, and the debrief part is where you grow the most. And so the question and answer, or the question within your tables will be nice to debrief, but I encourage you to continue doing it later on and keep bringing up these topics, because that's where the growth happens the most amongst ourselves. Listen without the goal of interrupting, lean into your discomfort, and challenge the systems that we're part of, both as healthcare practitioners, providers, within this conference today, and also as patients. I want to acknowledge that life is really difficult, and this conversation is also very difficult. We have had a pandemic that has led to the death of many, many people. Like Johns Hopkins is no longer even collecting this data any longer. Like so many people in our lives, both within the work that we do and our own local communities and our families, have been affected by this pandemic. We've had civil unrest with the Black Lives Matter movement. We have tremendous amount of natural disasters happening around us all the time. We have mass shootings. And it just kind of feels like, for me, 2020 was like this dumpster fire, but somehow we're still in it. So I just want to say thank you so much for the work that you do, and that I know this work that, like, especially the conversations that we're going to have, like both with the perinatal statistics that we received earlier, it's a downer, and oppression, it's a downer, but also there's liberation and there's justice at the end of it, and I just want to acknowledge that this conversation can be difficult. But you don't have to be on the train all the time. My mentor who taught me this work is like, imagine you're on the train of anti-oppression work, but it's really exhausting. You can take some time off and get off us to stop, but what we encourage you to do is to get back on the train. So I just acknowledge that it's difficult, but that the work is important, and I encourage you to be part of it. So the first concept, in order to kind of dissect what oppression is, how it is created in our society, how it is perpetuated in society, is called the ladder of oppression. And there's rungs to the ladder, and the very top of the ladder is the overarching aspect of it. But we're going to build the rungs. And first thing that I like to define is stereotypes. Stereotypes are things that we might hear in our lives, simple things that don't really matter. We don't have emotional association with them. They might be things we've heard from the media, our family, our communities, school, whatever it may be. And it might be like, all tall people play basketball, right? Like, whatever. It's not hurting anybody to have this stereotype, but you're grouping a group of people based on a characteristic that they can't choose or define. It becomes a prejudice whenever it goes from a fleeting thought in your mind to an emotional connection in your heart. So it might be something that you experience, something to reinforce that stereotype, a family member, the media, something a family member tells you about. You have now reinforcement of that stereotype, and it now has become prejudice. So it is a feeling emotion that you have towards a group of people. And then it becomes an action. So discrimination is action. It's when you act out that stereotype and that prejudice, and it might be conscious or unconscious. It might be microaggressions, for example. You may not know that you're performing microaggressions, or it might be just straight up discrimination and consciously that you're doing that and you don't care. So there are actions both you do and do not know that you could be participating in. And the last rung of the ladder is oppression. Oppression is the overarching structure that is reinforced by our individual actions. So there's unconscious passive participation that we can have in supporting oppression. And oppression, the people at the top, the institutions like the media industry, education, healthcare, why we're in this room today, the legal system, it's not a justice system, the legal system, those are all institutions of oppression. And they are consciously and actively creating oppression to exist. They're telling us what stereotypes and prejudice and how to act. They're reinforcing that information, and we are unconsciously and passively allowing oppression to exist. And what I'm encouraging us to do is identify our individual actions and how we participate in the ladder of oppression, and interrupting our unconscious and passive participation in it. We're saying no more. You can't tell me to feel that way. I'm questioning myself. I'm questioning these things that I've been taught, because maybe it's not correct. Maybe what I was taught that was reinforced to me over and over and over again in society is actually not correct. And that's hard to do. That's really, really hard to do. And I feel like I'm constantly being re-socialized. I constantly see things in the media, in the news, and I have to really think to myself, is that the truth? Because the ladder of oppression, the institutions of oppression are telling me to believe one thing. So this is constant work to interrupt this unconscious passive participation that I engage in oppression. And the other reason I bring up the ladder of oppression is because we can do something. And I think sometimes oppression can feel very overwhelming. What can I really do? And I think on an individual level, we can interrupt our behavior and our interaction with it, but we have to raise our awareness in how to do that. And so I'm going to try to give some skill sets in the end to kind of really allow us to tackle oppression. I really love this quote. It's by Ijeoma Oluo. She wrote the book, So You Want to Talk About Race. Maybe many people were exposed to that, especially when there's a lot of book clubs during the pandemic. She lives in Seattle, so you may have also seen her speak. But she said systematic racism, but I changed it to oppression. Our systemic oppression is a machine that runs, whether we pull the levers or not, and by just letting it be, we are responsible for what it produces. So what does that mean? It means that oppression is going to happen all day, every day, if you think of that cycle of the ladder. And until we say no, we're still participating in it. We're still allowing it to exist. We allow these outcomes. These outcomes that we talked about with Dr. Fiber, not on accident. I'm going to talk about other statistics, not on accident. It's because a ladder of oppression is created in a way to benefit some and to disadvantage others. But if we're silent in our participation, we are just as guilty. So we must interrupt it. We must not be part of it. So let's talk about intersectionality. This is a term that was coined by Kimberly Crenshaw, and more in the legal terminology. And she was looking at how different identities impact outcomes in the legal system. And what we've within social sciences, we've teased it out even more and added different identities. But basically, nothing lives in a binary. And so when we look at these identities, we have social identity, we have people who fall in our society. This isn't every society, but in the United States, privileged social groups, then you have your targeted social groups, so that's the binary, and then there's the gray area. It's going to be people who fall into the border social groups, and what is the oppression that's associated with it? I think I have a little point. Yeah, okay. So I won't go through all of these just in the interest of time, but I think one of the easier ones would be ability and class. I think those are the ones that are very approachable for people because they are physically seen or monetary. So ability, going to be people who are privileged, are going to be people who are temporarily able-bodied or able-minded. And why I say temporarily is because it can be taken away. Targeted social group are going to be people who have physical, mental, emotional, and or learning disabilities that cannot be hidden. They're very obvious. And people who fall in the border social group are going to be people who have temporary disabilities and or invisible disabilities. So you might break your foot and temporarily you fall into a targeted social group, but that can be fluid. You can go back to a privileged social group. It's possible that you fall into a border social group and you're never able to enter back into a privileged social group. But basically the border social group gives us that gray area to say that people live on the spectrum of between the two categories of privilege and targeted, and that oppression is called ableism. And I encourage you all to think about how you fall into this matrix. I feel like if you're in this room, you probably fall into a lot of privileged social groups, and even if you don't, the fact that you're able to sit in a conference and talk about outcomes of other people means that you're privileged to some extent. And so that's why I focus my talk on the privileged social group category, because once we own our privilege, because I think it's a lot easier to sit in our oppression, once we own our privilege, we can acknowledge that we have a voice that is very different from that of the targeted social group, because they're often not at the table. They're not here today to be able to advocate for themselves and to speak for what their needs are. Like, we're asking, why aren't people who aren't accessing prenatal care until the second or third trimester? Like, what is their barrier? We don't know, right? We have to look at statistics. We have no one to ask. No one's in this room today to tell us their own lived experience. So we are in the privileged social group today in this room. So I encourage you to access that privilege and think about what you can do to advance the life of those that are targeted. And I think just being at this conference is meaningful because you're asking these questions and you're wanting to know more and you're wanting to do better. The other piece is, how can you elevate the voice of those that are targeted and let them be at the table and be able to speak for themselves? So sometimes it means taking a step back and saying, I'm going to give you my seat. You know, I'm going to give you the microphone right now, and saying, I don't know best. So I encourage you to think about where you fall in the privileged social group and how you interact with the targeted social group, and what are ways for us to interrupt oppression by working in community and recognizing that we're all in this together, but that sometimes we're in the privileged social group, we don't recognize it. So that's my spiel about that. So let's go down to class. So people who are rich or upper class, I think that's pretty obvious. Those are going to be a privileged social group. They're going to be the ones making decisions for themselves to benefit themselves and to disadvantage those who aren't in that group. People who are working lower class, middle class, upper middle class, and that's going to be classism. There are going to be different identities that sometimes people have difficulty with, and so I would say like sex, people who are male, who are physically male, present, and then female, and then people who are transsexual or intersex. So it depends on their proximity to maleness. So it might be that your proximity to maleness allows you to have some privilege, whereas it might be that you never have privilege because you fall into those categories. And I can acknowledge that that is probably a very difficult border social group for us to like really comprehend, because most of the time I would say people who are transsexual or intersex are going to experience oppression. Any questions about that just before I get going? So just think about where you fall into the border social group, and when you fall into the matrix of oppression, and think about when you fall into the privileged social group, what are you doing to advance the lives of those who fall into targeted social groups or border social groups? Because that's what we're trying to focus on. We're owning our privilege so that we can use our privilege to defeat oppression. All right, so here's another, just a beautiful image of intersectionality, and that all oppressions are connected. So sometimes you might hear, well, I have to deal with this and you have to deal with that. That's not the same. All oppression is equal. Oppression is never acceptable. And so we all have to look at all oppression is connected, and because we live in community, our oppression is connected to someone else's oppression, as is someone else's privilege. Everything is a continuum. And so when we look at this in the terms of community and in the terms that no oppression is better than another, then we need to address all oppression. And so it has to be intersectional approaches to racism, intersectional approaches to classism, to sexism. Audre Lorde says it beautifully: there's no such thing as a single issue struggle because we do not live single issue lives. We are intersectional as ourselves. And so think about your intersectionality. For some people, this is an exercise you've never participated in. So it's kind of a fun thing to be like, oh wow, I never really understood that, you know, maybe I am white racially, but I'm a woman. So there are times where I feel I'm targeted, but there are times where I have privilege. And so how do you combine the two in order to move other people's issues forward? So let's talk about the history of OBGYN in the United States. I want to honor the mothers of our field, and this is a concept that was taken from the book Medical Bondage by Deidre Cooper Owens. And if you haven't read this and you're working in the field of OBGYN, I really recommend it. But basically, she's honoring the people who have given of their body and of their lives without even knowing it many times for our advancement of our knowledge in order to provide the care that we do. I start with Henrietta Lacks. She was a Black woman who lived in Baltimore who had terminal cervical cancer and went to Johns Hopkins University, and unbeknownst to her, had a portion of her cervical cancer removed. And it's these cells that never die and has been used in tremendous amounts of biotech research. Her family didn't know. They've not received any financial compensation for any of this research that has been done on their family member for all these years. This is a picture this was a painting that was up proudly in the Pfizer building, and this is Mariam Sims, who has been called the father of gynecology. He had a statue in Central Park for many years, and he experimented on enslaved women in the South, and this is a picture of Betsy, Lucy, and Anarcha, which were the only 3 women he ever used their first names of in his research, but he experimented on many, many women who had fistulas, did not use any pain management, and optimized his surgical technique, moved to the East Coast, and made tremendous amounts of money, and then was named the father of gynecology in the process. And there is still an instrument, the instrument he's holding right here, it's called the Sims retractor. We still say that in medical terminology, like when we're in the operating room. So we've renamed it to the double-headed retractor, but we still were honoring this person who did these horrible acts. Birth control is both liberating and has given people opportunity and access, and in the same process has tried to control populations, especially those that fall into the targeted group. In the 1970s, 1/3 of women in Puerto Rico were sterilized. It was the highest sterilization in the world. In the South, we have Fannie Lou Hamer, who came forward and was one of the major advocates of something called the Mississippi appendectomy, where people were getting sterilized against their will, against their knowledge, without their knowledge, as young as like 10 and 12 years old. Because of a paternalistic system, doctors would say, oh, you need a surgery, and then they would go back to the OR not knowing what was being done, and they were being sterilized against their will or knowledge. We had the Dalkin shield, which was an IUD that was causing death amongst women, which is why IUD rates dropped significantly in the United States despite being a really effective birth control method, because people were dying and people had to go to the streets to advocate to remove this from the FDA. And this is from 2020. Forced hysterectomy is in ICE detention centers. Like, this is not something of the past. These grotesque events, they're not from the past. They are currently happening today. And like, as we work in the world of perinatal care and women's health care and people who have the organs that we're treating, we need to address that these outcomes are devastating and horrible, and that we should not ever allow something like this to occur to this day. So this ties into the statistics that we've already heard a little bit, and I will tie into that as well. Oftentimes you'll see statistics that are only looking at one single issue, and it's race, because it's the easy thing to point at. But when we look at intersectional issues, though I do not have the statistics, you will see that typically you're going to have people that are going to continuously fall behind in the process of statistics in terms of outcomes. So here we have maternal mortality. This is from the CDC, that Black women are consistently having higher rates of maternal mortality. This is for Pierce County, preterm birth, so people who are giving birth before 37 weeks. We see people from different racial identities that are non-white that are consistently having high rates of preterm birth, specifically people who are American Indian, Alaska Native, which is very different populations, and Black or people identified as African American. Also, I always wonder, like, racial statistics, is it they defined it or somebody defined it for them? Infant mortality in Pierce County, again, consistently elevated for people who are different ethnicities that are outside of white, and so consistently higher for people who are Native or people who are Black. So this is our neighbors, this is our community. Very premature neonates, this is from Dr. Feiberg's presentation today. So we have Alaska Native, people who are Pacific Islander or Black, consistently having higher rates of very premature before 32 weeks deliveries. We have cancer mortality. American Indian and American Native and Black women are consistently dying of cervical cancer. And it's easy to say the statistic, but why? Late identification, inability to get to a good healthcare system, not having insurance, not having transportation, whatever it may be. There are so many aspects to it that tie into the statistic. It's not just a person in isolation just because they're Black or Native. I think this map to me perfectly demonstrates how privilege and oppression and people who have targeted identities get different resources. So this is Chicago, this is COVID. The COVID-19 deaths you see is south side of Chicago. That's going to be your people who are low income, people who come from different racial identities, a lot of immigrant population, refugee populations living there have the highest rates of COVID-19 deaths. Where is COVID-19 vaccination happening? Downtown Chicago. The people who are making the decision. You know, up here, this is going to be like the wealthier parts of Chicago, so the people who needed it the most did not have access to it because they weren't the decision makers. They didn't get to decide who was going to get what vaccine and when. The decision makers said, we need it for ourselves and our families. So this is like the perfect example to me. When I saw this map, I was like, okay, this is the, duh. You know, like, of course, but it was just so nice for me to see it in visual representation. But I know this is all negative, and this is all heavy. But what happens when we raise our consciousness in medicine? We change outcomes. There's the child labor after C-section calculator. This was a calculator that's used in medicine for patients who have had prior C-sections to tell them, what's your ability to have a vaginal delivery after a C-section? We know vaginal delivery has a decreased risk of infection, of injury, of like just recovery in general. So vaginal delivery is ideal, right? And we were telling people that they had less ability for success if they were Hispanic or if they were Black. So once we removed that, more people were able to access having a child labor after C-section. There was also a racial category for hemoglobin levels in prenatal care, where Black patients had a lower level cutoff for anemia diagnosis for treatment. So that led to more transfusions, more risk of needing transfusion after delivery, and less ability to intervene prior to the delivery to give them iron. But now we've changed that, ideally. GFR was used, so this is a kidney evaluation that was used for transplant. So people were being told that they weren't transplant candidates because there was a calculator that was using people's race in it to tell them whether or not their kidney function was bad enough in order to be a transplant candidate. So now that we've questioned these things, we're changing these things. So that's why we have to raise our consciousness. We have to say, we're not going to passively participate in this and say, oh, the TOLAC calculator has this, I'm just going to keep using it. And then emphysema, the same thing. Diagnosis of emphysema was changed just because of people's racial categories. I love this image because I think it demonstrates the challenges somebody may have in terms of accessing anything. Like, I remember being in med school and we would have these conversations. People were like, well, I worked really hard to get here too. And I was like, yeah, but are you poor? Did you grow up poor? You don't have anybody in medicine in your family? Like, you know, like the life is so different. And so when we think about patients accessing healthcare, like, yeah, life is hard for everybody, but did you have to deal with sexism and racism and classism and genderism, and you had a ball and chain on you? You know, like, and you still got to the finish line, and that's sometimes what patients are having to deal with to try to get prenatal care. You know, when we're asking, why aren't they coming to prenatal care? Well, maybe they don't have transportation or child care or education or health insurance, whatever it may be. Those are all the barriers that have been led to that because of oppression in general. So that's what we're trying to do. We're trying to equalize it. So justice and liberation, this is how we deal with oppression, because we need to sit in a space that justice and liberation are possible and that we are capable of reaching this. So I love this image. You know, we have this fence, this is their oppression, and everybody's given the same box. This is equality. Like, that's not going to really reach the outcome we want, right? Not everybody can look over the fence. Equity is acknowledging that not everybody has a fair shake at life, but maybe we can give these people a little bit more resources. And I think that's kind of like the work that we're trying to do, you know, and I was just talking, is it Cheryl with the diaper bank? And, you know, like menstrual products, like those are the things that we're like acknowledging, you know what, people don't all have access to this stuff, so how do we give them access to it? So that's equity. The reality is there's a tremendous inappropriate distribution of resources, and liberation is when we remove the fence. And I remember when I first saw this image, it had these three, and then once the fence was removed, it was like liberating for me to see that. I'm like, why didn't I ever question the fence to begin with? Like, we should get rid of that damn fence. But at the very least, we should try to reach equity so everybody can look over the fence. So let's go back to the matrix of oppression. If we looked at each one of these different oppressions and we said, how can we defeat each one of them? I think that would be amazing. I really want to see that one day. And there are concepts out there like economic equity, social equity, bodily autonomy, equitable healthcare access, distributive justice. Those are all things that we can access to make a difference in our communities and our lives. But the work has to start within ourselves. And I encourage you to be part of this process today. This is the ecological model. once you do this work, it ripples. It ripples into your family life, your friendships, your community, your work community, and then ideally into institutions that can make public policy. You know, like, I think the work is critical to start with yourself. So even if you feel overwhelmed with the process of anti-oppression work, understand that just small actions will count and do count. So how to be anti-oppressive? I don't have the answer. I'm sorry. I wish I did. I wish at the end it would be like, take this drug. But it's not that easy. It took us a life to get to this point of living in oppression, and it's going to take another lifetime to try to get us out of it. But ideas, we can continue learning and leaning into our discomfort. We can sit in advocacy and support with our community. We can listen to others and hear them, really hear what they need and what they want. Discuss concepts of anti-oppression with your friends, with your community. Learn about principles of anti-oppression in your daily life. You know, challenge yourself to change your language. You know, if somebody tells you their gender identity or how they want to be referred, or just, you know, in any way somebody corrects you, please try to do your best to sit with that and like challenge yourself to make sure you're doing that as best as you can. Interrupt oppression when you see it. And I love to do this work within healthcare because at least in the medical field, we see it right then and there. Like, you'll see a nurse just not do something for a patient, or a doctor make a disparaging comment, and right then and there, you can interrupt that and say, can you tell me more about that? Can you tell me why you wouldn't do that, or why you said that? You know, you can actually interrupt oppression on a daily basis, unfortunately. Use your privilege, and this is, my friend coined this, privilege cash, and so I did this in residency where I maybe brought up too many things too fast, and it really overwhelms my superiors, and so I started using other people who had privilege cash, you know, like somebody who like maybe identified in a way that wouldn't be questioned if they brought it up, and I'd be like, hey, you really need to go say this about this situation. And it was, of course, somebody I trusted and everything, and then it wouldn't be me saying it, but at least the concept was there and something could get done. So use your privilege cash or someone else's. Advocate within your systems. Education system, clinical settings, public policy, you know, advocate for pay redistribution. I think if we just did that, like, that would just tremendously change our society. So, again, this work is hard, but it's possible, and I know that maybe we've all heard of like being woke, and this is part of the process, is waking up. And sometimes it takes us to have a sentinel event to wake up in the work that we do with anti-oppression. And so this is from Bobby Harrow, it's online, but it's the cycle of liberation and how does it happen. So you have this sentinel event that kind of raises your awareness about oppression as it exists in society. And then you start this work, you know, you start reaching into your community, you start doing this interpersonal work and questioning where you sit, like maybe you go through your own matrix and think, wow, I never really owned my privilege in this particular aspect or this identity. And you build community in the process, you coalesce, and you make systemic change. And at the core of it, I encourage you to have self-love, self-esteem, balanced joy, all the things that is super easy to say out loud and very difficult in our day and age. But the cycle of liberation is possible, and I think that's the joy of this process, is finding people that challenge you, because the work is hard sometimes, and can push you to be better, ultimately. So, back to the matrix, evil, evil, evil. But, you know, if you're following the privileged social group, own it. Do something about it, and help those that can't be there to advocate for themselves. So if you want to go fast, you go alone, but if you want to go far, you go together. And shameless plug for my organization. So if you're interested in any further, there's trainings that are 2 hours as much as a whole week. So highly recommend. I think the in-person trainings, you'll do an activity and then the debrief. That's the growth. The debrief is the growth. So that's what's always limited when we don't have time. Some books, they're great, but not enough. So I encourage you. That's why book clubs are nice to kind of talk through things. So these are just some easy primers on just kind of racism. These are really good books on kind of the social construct of the United States and oppression within the United States. The People's History of the United States is a textbook, so it's an alternative to a history book within high schools and middle schools that people can use. And I mean, I've like openly wept reading some of these books, and then these are really wonderful books in the terms of obstetrics and gynecology and the roots of why we have the outcomes that we do. And trainings and discussions. Oh, and this is a QR code. Sorry, you can't see it completely, but it's tons of resources, articles, like Instagram accounts, all kinds of stuff if you're interested. And so I leave you with this quote: if you have never stood with the oppressed, there is still time with them. So thank you so much.
We have time for questions. So much time. Chris Laddish again from the Bessler Center is going to walk around. Please raise your hand if you have a question.
I have a question and a comment. Comment, first of all, is amazing, thank you. Because I'm so happy when someone who doesn't look like me actually speaks on things that affect me. So thank you. Because a lot of people miss the point that our system got this way because of the history of the United States. And we're still playing into that system, and we even recognize it and say, you gotta understand why it even is happening so we can try in the next 100 years for our future generations to not have to deal with what we're doing now. So thank you very much. I've read every single one of those books that you put.
Okay.
And shameless plug, the movie, you know, is how old.
Oh, okay.
So
Thank you.
It'll make you practice like a movie.
Yeah.
Anyway, do you do also classes or maybe speak with teams when you're trying to have like a, I know we focus on anti-racism, but anti-oppression, it was just more genius, and it's actually at the top, which makes sense because the one picture where you see the guy running, he has a straight line, and you have a black woman running so many circles, I can't express how the majority of us deal with that on a daily basis. We're just as smart, have the same education, but I have to work 5 times harder just for you to notice me. And that was perfect. I think when we have that as a screensaver, just to keep motivating me, to keep going, because at times, because we go through so many obstacles, they don't want to move. That is the reality of a lot of black women and black mothers. The reason why we don't come to your classes, your WIC offices, your hospitals. This is how we feel just being in your presence. So it's easier for black women or women of color to say, I don't want to do it because I'm sick of being persecuted and oppressed. That is one of the things I have seen in child death reviews where I have a mother of another color won't even go to get prenatal care because of how they feel, of these systemic racism that they get on a daily basis. So that's one aspect that if people will actually see, or people actually go through the women of color, then you'll understand why we're not coming to your offices to get these services, because you're not trying to make sure you're in our neighborhoods giving us these services. We have to come to you, and the language barrier. There's a major issue in Washington, but because we don't have a system that will actually allow for, a specific language to be able to talk honestly and openly with his mother, you just dismiss it and go on to the next point, so they don't feel safe and comfortable, so therefore they won't go get prenatal care, which means by the time they have this baby within a month or two, because they did not get the education, now we have, I'm doing a child review on an infant side of the it's all in a circle that you will actually look at. So thank you again for recognizing that. And I would love, just to pick your brain more about this, see how we can more challenge ourselves in each group. Because like you said, it starts with the group and then it carries out. So thank you.
Thank you. Thank you for sharing, and I'm sorry. I'm sorry you're tired. I wish I could take it from you. It's just, I think what happens and what our society has been taught is to be very individualist. And we forget sometimes that society is constantly telling us to be very individual and to separate ourselves from community. So I'm sorry that you're feeling alone or that you're feeling like you're struggling that much more. And I hope that there can be more community and more support around you to make you not feel so alone and so tired. I mean, I completely agree with everything you're saying, and I think that's the challenge. You know, as the prenatal doctor, I know that my patients have disclosed, like, I didn't feel safe, I had a really bad experience last time, so I'm going to pick and choose the appointments that I'm going to go to, and usually I'll start at second, third trimester, so I have to leave, like, you know, have less trauma through the course of the pregnancy, and you know, like, that's where I think it's going to be the most important, whereas, you know, like, when we look at the data, you know, there's a lot of intervention that can happen earlier in the pregnancy and a lot of support, so it comes from a point of patients trying to protect themselves from an oppressive healthcare system that really isn't created to take care of them. So thank you for sharing that, and I think that's kind of the point of why we're here is how do we change a system to meet our needs?
Thanks, Mariam, for being with us, and we're just so happy that you're here at Puyallup, just, you know, sharing your work with us. I just want to say thank you for calling out the statistics for Native American, Alaska Native, and Native Hawaiian Pacific Islander people. I'm looking around this room, and I think I know everybody here who are Native or Pacific Islander, and there's a problem with that. But also just calling out the insignificant, like statistical insignificant part of that as far as rates go. On top of that, I will also say that according to the mortality report, income is not a protective factor of who dies and who doesn't. And I understand, you know, your chart, and I don't discredit that chart, but income is not a protective factor.
Oh, definitely. You know, we see people from upper classes still having really adverse pregnancy outcomes. I mean, remember Serena Williams, who had PE and had to advocate for herself, like, no, income is not protective, but it definitely participates. You know, if you're low income, definitely your ability to advocate is quite different. I completely agree, and that research is well played out, that even some identities are so powerfully negative effect in a negative effect that it doesn't equal out when you have a privilege from another category. So thank you for pointing that out. And kind of tying back into the Pacific Islander thing is we group tremendous amounts of people as if they're homogenous, you know, and somebody from the Marshall Islands is going to have a very different access and ability than someone from the Hawaiian Islands, you know, like, so it's just like you're neutralizing groups so completely and just saying they're all the same, and that is not the case at all. Like you have very different groups that you're putting into a large pot and saying they're all having the same outcome, and so that's why when we tease them out, saying who's from a rural community, who's from the lower class, who has different education status, who is an immigrant, like all of those aspects totally tie into their outcomes and will be very different if we actually looked at it from an intersectional point of view.
Thank you.
Yeah, thank you. I'm available for hugs.